is very important to deal with bronchoalveolar dysplasia. Thanks a lot. Bismillah ar-Rahman ar-Rahim. My presentation today about rare case of food protein-induced enterocolitis. I report here 40 days old newborn with vomiting, fever, diarrhea, who was exclusively breastfed with some peculiar clinical features. He's born about 1 year ago, 2022, September, when date of admission was 19th of October, 2022. He was almost about 40 days old. He's born from 9% single parents, Gravida 1 para 1, no history of abortion, nor maternal diabetes, nor IUD, nor premature rupture of membrane, and no history of drug intake. But the mother had hyperthyroidism and she was on carbimazole, but not during pregnancy, and the father had multiple sclerosis. He was full-term baby, born by cesarean section, and no cerebral asphyxia nor NCGE. With the past medical history of stool tinged with blood for 7 to 10 days before admission to my hospital. This on day 1 of admission, he had vomiting once, very low grade of fever, 37.8, 37.9. That's it. He was lethargic, and his color of his skin, he looks like ashen gray appearance. And this is his photo when he came to the hospital. And this is the ashen gray appearance. By examination, lethargic, crying. Weight at 40 days was 3 kilos 100 grams, minus 3 SDS. Length 51, minus 2.4 SDS. Its circumference was 35.5 minus 2, almost SDS, and mild signs of dehydration. Heart was normal, no abnormal sounds and no adventitial sounds. Neurologically positive Moro and grasp reflex, but bore suckling. Hemoglobin was 9.2, platelet was 722,000. TLC was 10,500. Coagulation profile was normal. Albumin initially was 3.3. Creatinine and urea and random blood sugar, sodium and potassium, all were normal and lip function as well. On septic screening, on admission, CRP was 39.7 milligram per deciliter. Urine culture, no gross. Stool culture, no gross. And blood culture as well, no gross. Day 2, he has diarrhea 6 motions per day, but no vomiting. And the amount of diarrhea varies between 20 cc to 120 cc in each motion. Total was 400 cc, and fever varies between 37.8 and 38 degrees centigrade. Diarrhea on third day, 10 times per day, varies from 35 to 130, with total amount 670. And his weight was 2.8 kilograms, almost more than 250 cc per kg. It was watery, but no mucus nor blood. He received the fluids and it was on breastfeeding. The mother was advised to stop milk and dairy products for fear of cow milk allergy, and local blood in the stool was positive, and weight drops from 3.1 kilogram to 2.8 kilogram. Day 4, diarrhea was 12 times per day. It was watery. The total amount was 710 cc. Baby was breastfed, and hypoallergic formula was advised. Weight was 2.7 kilogram. Urine castor was good, and CRP was 67 before 39.7. Day 5, vomiting 4 times per day, and diarrhea 8 times per day. It was severe and watery as well. Day 6, The baby has severe water diarrhea, about 700 cc per day. Central venous line was inserted and CVB was 1 after plenty of fluids. So I can imagine this central venous pressure was less than 0. So it was minus. Capillary fill time more than 3 seconds. Blood pressure was maintained, 81 divided 44. pH 7.23, BCO2 was 46, bicarb was 14, sodium was 149, potassium 2.7, albumin 2.5. The baby was shocked. He received intravenous fluid in addition to amino acid formula, probiotic, zinc, and oral hydration solution as well. Actually, at this stage, we put the assumption that this baby has severe gastroenteritis, whatever the etiology, or cow milk allergy, or post-COVID. One of the parents had COVID. That's why we thought about COVID as a possibility affecting the gastrointestinal tract. In the context of bicarb was low, severe acidosis at the time, it wasn't explained by his condition. MS-TMS was done, organic acid in urine was asked for, COVID-19 IG and IgM was done, ammonia and lactate as well, and all these investigations were normal. Pediatric gastroenterologist professor was consulted. He advised to stop feeding for 12 hours to detect if diarrhea is secretory diarrhea or osmotic diarrhea. Advised amino acid formula for 3 to 5 days, stool analysis and serum albumin as well. Day 10, occult blood stool was positive, echo was normal, ultrasound abdomen was normal, cranial ultrasound was normal as well. Lab on day 10, CRB increasing to 56 milligram per deciliter, procalcitonin was 0.8, maximum value is 0.05. Ferritin was higher than normal, 617, maximum value is 375. LDH 467, D-dimer was positive 1.35, and thyroid function TSH and 3T4 was normal. Day 13, hemoglobin was 6, heart rate was 140, and they received the blood. Day 23, weight was 3.3 kilogram, hemoglobin was 9.4 gram, breastfeeding once per day, and he was on amino acid formula. He discharged from the NICU with weight 4.3 kilogram minus 1, as you see before, it was almost minus 3 CDS. And discharged from the hospital, his weight was 4.6 kilograms. On the follow-up, CRP was 1.3, procalcitonin was normal. Day 56 outpatient clinic, CRB was normal, calprotectin was normal as well. And the baby was doing well, extremely well. At the age of 1 year, nutritional history, he tolerated most vegetables and fruits, oats, rice, bread, egg yolk, boiled chicken, fish, potato, meat soup, small amount of meat. All these were introduced and tolerated. When the meat was increased in amount, the baby developed severe persistent vomiting. Mucus filled in the stool, frequency increased, he became lethargic, anorexic, and insomnic as well. At 1 year, we stopped meat. And the diagnosis was made food protein induced enterocolitis syndrome. This is the baby or the infant at the age of 1 year. Developmentally, he is extremely fine. Motor, social behavior was excellent. Thank God. At the age of 1 year. But what is FBI, food protein induced enterocolitis syndrome? It is non-IgE mediate gastrointestinal food hypersensitivity, usually triggered by cow milk or soya protein or other dietary proteins. It represents the severe end of the spectrum of food protein-induced gastrointestinal disease. The incidence of cow milk FBIs is 0.34%. The incidence of FBI to any food was reported to be 15.4 per 100,000 in the first 2 years of life in one study. In 2015, there's a diagnostic criteria for food protein-induced enterocolitis by Leonard Nord. One major criteria and 3 minor criteria. The major criteria: vomiting within 1 to 4 hours after ingestion of the offending or suspected food, and absence of classic IgE-mediated allergic skin or pulmonary symptoms. Minor criteria: second or more episode of repeated vomiting after eating the same suspected food. Recurrent vomiting episode from 1 to 2 hours to 4 hours after eating a different food. Extreme lethargy with any suspected reaction. Marked pallor with any sign of suspected reaction. Need for emergency department visits with any suspected reaction. Need for intravenous fluid support with any suspected reaction as well. Diarrhea in the first 24 hours from 5 usually from 5 to 10 hours within 5 hours. Hypotension and hypothermia. These are the major and these are the minor. There should be 1 major and 3 minor criteria to diagnose food protein-induced enterocolitis. It is non-specific symptoms, usually in the absence of specific confirmatory tests. That's why FBI is underdiagnosed. This delays the final diagnosis and increases morbidity associated with extreme investigation and unnecessary investigation and hospitalization and treatment as well. The recognition of multiple manifestations of FBIs with increased awareness for healthcare professionals will improve its management and will decrease the hospital stay and unnecessary investigation. FBIs has to form either acute or chronic. Acute, repeated vomiting 1 to 4 hours after the food ingestion, vomiting, lethargy, pallor, ashen gray appearance, dehydration, hypotension, and even hypovolemic shock, as we have seen in our patient. Acute typically lasts for 24 hours from exposure, and children are usually asymptomatic between episodes. And now we have the chronic FBI. It is less well recognized after ingestion with daily ingestion of the offending food. It may present in the first days of life, and usually the age is less than 4 months. It's characterized by intermittent vomiting, chronic diarrhea, abdominal distension, dehydration, poor weight gain, failure to thrive or filtering growth in an infant fed with cow milk or even soya formula. The chronic disappears after elimination of the offending antigen. Subsequent feeding with triggered food will induce acute FBI syndrome. Although most commonly described triggers are cow milk or soya protein, FBIs may be induced by solid food and rice, oats, corn, meat, poultry, vegetable, fruit, and even seafood. Most infants with solid food induced FBIs react to more than 1 food protein. both acute and chronic FMI. Lab finding usually anemia, hypoalbuminemia, elevated white cell count with shift to the left, eosinophilia, thrombocytosis, metabolic acidosis. Full examination and radiologic test and even endoscopic evaluation does not provide any specific finding and should be only used in the differential diagnosis to exclude other disease. Differential diagnosis, infection is the most imperative diagnosis to exclude. Infection is very important to exclude an FMI, acute FMI syndrome. Diagnosis implies on high index of suspicion. It is often delayed due to it is rare disease and low awareness of healthcare professionals and the absence of classic allergy symptoms, either respiratory or cutaneous manifestation, non-specific, late presentation, and lack of definitive diagnostic test. Oral food challenge is the gold standard for FMI diagnosis. And infant with typical history, they don't need any confirmatory test. Oral food challenge is done only if history is abnormal or not classic. In FMI, oral food challenge protocol, the protein challenge is administered in 3 equal doses over 30 minutes. The management depends on the condition. If it's severely ill or shocked, aggressive intravenous fluid resuscitation for patients with hypovolemic shock. Mild to moderate, he can receive oral hydration. Some patients may even require aggressive lines of management to hemodynamically support in troops and admission to ICU or NICU. Epinephrine has no role and it is not an IgE mediated. Long-term management, dietary elimination, infant with cow milk allergy, and soya FMI should be supplied with casein formula, hydrolyzed formula from 10 to 20 may require as a formula for our infant. Breastfeeding should be continued as it is very rare as FMI to protein through the breast milk is very rare. That's why we can continue breastfeeding. These are the summary for our patients, and this is one of the references, but it includes all the reference for this literature review. And this, the baby, when he came, he was 41 days old. He was emaciated, the gray color, toxic clot, mild abdominal distension, lethargy. In the NICU, I was really shocked. I was afraid that we may lose this child. And this, when he was 1 year old, playing, walking, everything was excellent. Thank you, God. And this our professor, and this is our dear professors, Dr. Hamza and Dr. Hamid, and this is William Hamilton, and it's Malcolm Donaldson. And thank you very much indeed. Thanks a lot.
Thank you, Dr. Sameh, for this important case that direct the attention of all the doctors to this rare case. I cannot see any questions.
Dr. Safa, may I ask a question, please?
Yes, Dr. Rada, go ahead.
Dr. Sameh, whenever we have breast milk in this condition, we usually advise the mother to withdraw all forms of cow products.
Yes, yes. In the history, you can see that the mother told to stop all dairy products. And this was done because the assumption at first was cow milk allergy. We didn't think of FFIs because we weren't aware of FFIs at this time, but it was in differential diagnosis as well. But yes, that's what has been done actually. Yes.
Yeah, it's actually a very interesting case. We have had a similar case in our NICU, and we passed through all the sequence of investigations and events as you had exactly until we reached the diagnosis and the baby was managed on amino acid-based formula. Thank you very much, Professor.